Hello, hello, house.
Hello.
Good evening. Good evening, everybody. I don't know, the attendance keeps being very poor. It's like we give maybe extra 7 minutes grace, then we can kick off. Whether we are 10 or 5 does not really matter. What matters is to keep the pace moving. Now about 15 participants presently. This is indeed poor. Okay, bye. Exactly in the next 10 minutes, 9:19 will kick off. Whether the number improves or not. 2 minutes more. The next 2 minutes, we'll kick off. Yes, we have to kick off. Good evening, everybody. We've waited for so long now, so we don't need to waste much time again. The people or the persons that really want to participate would have participated by now. We are 15 minutes behind schedule. So we have to commence the necessary protocols of the rituals. The top of the agenda should be the opening prayer. Ladies and gentlemen, I don't know whether Dr. Ibrahim Abbas is right there in the house so that he can lead us in opening prayer. Is he there? Hello? Hello, am I audible enough? Hello?
Yes, we can hear you clearly. We can hear you.
Okay, I don't know if Ibrahim Abbas is not available, whether Dr. Anne Imoru, whether he can lead us in opening prayer. Dr. Anne Imoru, are you there? It looks like some people, majority of them.
Here.
Please, can you lead us in opening prayer?
Okay. In Jesus' name, Heavenly Father, we thank you for this opportunity to be together again, to learn and to improve our skills as pharmacists, as clinical pharmacists. Lord, we give you all the praise, we give you all the honor. Thank you for the presenters of today's teaching. The topic of today, emerging strategies in HIV management. Thank you for the speaker and the moderator. We ask, Lord, that this whole training today will go seamlessly and let practical knowledge be impacted. And oh Lord, we ask, so Lord, that CPAN, as you have made it, should thrive wherever we find ourselves in Jesus' name. Thank you, Lord. In Jesus' name, amen.
Amen. Thank you so much for that wonderful prayer. Then we have to kick off. From the rituals, we have to welcome our national president, the #1 pharmacist in land, in the nation, Professor Cyril Obiano-Fisifo, is not here present. But we cannot kick off without welcoming him. Welcome our wonderful, working, and always dogged, resolute, and resilient national chairman, Dr. Joseph Mado, FPSN, FCP firm. Welcome the elders of the profession, fellows of PSN, distinguished elders in the house, distinguished HODs of various departments, various facilities, various faculties, distinguished colleagues, my erudite IPCC, my erudite secretary committee, distinguished professors in the house this night, distinguished pharmacists of outstanding excellence in different endeavors of their life. At this particular venture and at this premise, I welcome everybody on board. Permit me, ladies and gentlemen, to read biography of the presenter tonight. Is no other person than Dr. Abdulmumin Issa. Dr. Issa holds a Bachelor of Pharmacy from prestigious Ahmed Bello University Zaria, PharmD from prestigious University of Benin. He has masters to his credit and PhD equally to his credit. Dr. Issa is early career lecturer. He's equally a member of Clinical Pharmacists Association of Nigeria. He's a member of PSN. He's a brand new consultant and certified infectious disease specialist. He's a lecturer in the Department of Clinical Pharmacy and Pharmacy Management, University of Nigeria, Nsukka. This automatically makes him a great lion. Dr. Issa has co-authored 40 peer-reviewed original research articles in reputable journals as of 2021. Ladies and gentlemen, know it that Dr. Issa was employed to the services of University of Nigeria and Nsukka in 2016. For a few years, he has done so much credibly well in the voyage of academics that makes him outstanding among his peers and contemporaries in the field of academics. He's active reviewer to many Scopus, Siamago, and journal citation reports, index journals, export value in health regional issue, Journal of Pharmacy Practice, FIP's Pharmacy Education, the UK Royal Pharmaceutical Society, Journal of Pharmaceutical Health Science Services Research, +1. Dr. Issa has many papers that need to equally be published. That actually will let us know the extent he has gone in the field of academics. Ladies and gentlemen, Dr. Issa is a consultant infectious disease pharmacist. He is a supply chain expert certified by Supply Chain Analyst, International Supply Chain Education Alliance. His research interests is in health economics, outcome research. He has a bias in HIV/AIDS prevention, treatment, care, and pharmacy education. Ladies and gentlemen, if I begin to talk much about this young, vibrant, energetic, enthusiastic, and intelligent pharmacist, it will take us a long time, and we will have much time behind our schedule. Ladies and gentlemen, permit me to formally welcome on board Dr. Abdulmumin Issa to do a justice to what he has been doing in University of Nigeria and beyond. Dr. Issa, I give you the podium to take over and do your presentation. You're welcome on board.
Thank you very much for the kind introduction, my boss, Dr. Solomon Wafuru. I think the introduction has already taken care of what we are to do today. So I will not waste much time again on the title slide. The title of the presentation tonight is Emerging Strategies in HIV Management. And in case we have any issues with network, you bear with me tonight. It's just rained heavily at Nsukka and it's still drizzling. So whenever there's any issue with network, please bear with me. We'll try to make up for it immediately. My presentation will follow this outline. We will introduce why we're talking about emerging strategies in the management of HIV/AIDS. We would like to know what is management of HIV and what are those new things that we're talking about in HIV management. Thereafter, we'll talk about prevention and treatment. As you will see from the introduction, it will be obvious that whenever we mention HIV management, we're interested in two things: prevention of the transmission of HIV and the treatment of the infection. For the two topics, prevention and treatment, I will take us to back a little to where we are coming from, where we are at the moment, and what are those emerging strategies that are being used by scientists world over in the management of HIV. I'll tell us a few things about the future direction in the management of HIV, talking specifically about the use of vaccines and where we are now in terms of finding a cure to the HIV disease. And I will conclude with just one slide. HIV infection and its management are two topics that about everybody that you meet on the road will tell you that they have one thing or the other to say about it. Everybody is an expert, unquote, about HIV. They will tell you that I read on a blog recently, I read in a textbook recently, I read online recently, or when I was a core member, when I was a student, when I went for volunteering. So this is a topic that people say different things about it, but how true, how authentic, how genuine are those information? As a scientist, we talk about evidence-based medicines. And so whenever we talk about HIV as professionals, we should focus on the source of information. Is it a primary source of information? Is it secondary? Is it tertiary? Primary involves things like original research, where you are the person that reads it yourself, observes for the first time, or secondary, where we have collection of databases, as we have in things like Scopus, PubMed, etc. Or tertiary, where we have textbooks and even treatment guidelines. But the good thing about HIV is that because of how much of a pandemic it is, we have frequent review of the treatment guideline. So it is rare for you to come and tell people about a disease today that is not in the treatment guideline of HIV. I think the most recent treatment guideline for the treatment of HIV was that was unveiled last year, August, at the International AIDS Society conference that was held virtually and physically in Germany. Now, what do we mean by HIV management? Before, when I say before, I mean before the 2015 treatment guideline. If somebody mentions HIV management, two things come to mind: treatment and care. I'll talk about the care because we all understand what the treatment is. But for care, once upon a time, you used to hear them saying that this patient is HIV positive, this patient has CD4 count of 1,000, therefore he or she is not on treatment yet. Or they'll tell you that this woman is not on treatment for her sake, for her own disease, but because she's pregnant, she's now on a medication. That's what we call care that time. But today, with the recent guideline that came in 2015 until recent, nothing like care again. We'll have two things: prevention of the disease in those that are negative, or treatment of the disease in those that are HIV seropositive. I must tell us that ever since the 1980s, when the first 5 people that came up with the disease in America, then France, came about the first report of 5 gays that came with diseases of unknown origin that were later found to be PCP, scientists have never rested in the search for a treatment for HIV. It has been a multidisciplinary healthcare effort. Pharmacists, physicians, nurses, scientists, microbiologists, people that are involved in biological sciences and other things like that. So at every point in time, we talk about newer strategies until we get to a point where we can see that it is no more a pandemic, or even if it's a pandemic, we say that it's a disease that we can live with it without any problem. So this presentation will talk about prevention, then talk about treatment. So what are the things that we know about prevention? In the world of HIV, I'm sorry, it seems it's covering the heading, but this heading is treatment. So what is prevention? In the fight between HIV infection and the host, we only have two things that are in play: the CD4 count of the host and the quantity of the virus that has invaded the system. So it's always a fight between increasing the CD4 count of the patient while trying to reduce the load of the virus in the patient. As of today, the main interest of science is that we should have a decreased level of the viral load in the patient. That has been taken by WHO as the main variable that should be considered in clinical outcome of the patient. We want the viral load to be as low as possible to a point that we now call it undetectable. Then the acronym comes, U is equal to U. What we say undetectable equals untransmittable. What this means is that as far as a patient is HIV positive, but there is no standard blood test that can detect the presence of HIV in the patient's system, that person is considered to be undetectable. Different authorities used to give different definitions to undetectable. There are some that will tell you that it is when it is 200, when the count is 200. Some come to as low as 20. Some will say 50. CDC will tell you 20 sometimes and will tell you 50 sometimes. But the general, the one that is used mostly, even by the third world nations, is 200. So at any point that the viral load is undetectable to any standard test, then the patient is said to be undetectable. But that does not mean the patient is cured. This person is still positive and the person is on treatment. At this point, it has been confirmed from different multi-centered tests over several years that at that point that the patient is undetectable, that patient cannot transmit HIV to another person that is HIV seronegative. So where are we now in terms of the prevention of HIV using the concept of if somebody is undetectable, undetectable, that person cannot transmit the infection. The first and the most common that we have used is prevention of mother-to-child transmission of HIV infection, what we call the PMTCT. It has been proven that mother-to-child transmission of HIV is responsible for the prevalence of HIV in children that are less than 15 years in most parts of the world. And this transmission occurs in between a percentage of 25 to 40%, whether during pregnancy itself, or during labor and delivery, or breastfeeding of the mother. The import of PMTCT is how do you prevent this transmission in any of the three stages. The first is pregnancy, the second is labor and delivery, and the third is breastfeeding. PMTCT must note that this intervention is of great importance, not just to the mother or the infant, of course for the mother, because no mother wants to have a child that's HIV positive. For the infant, because this is somebody that is coming to the world afresh and we don't want to have any problem with the child. But for the community and the health system, if we prevent transmission of HIV in new patients, it means we have new people to take care of. It means the health system will have less burden. It means the clinicians will have less people to take care of, and it means there will be reserve of health expenditures. So in PMTCT, it involves a four-pronged approach, wherein the first is we prevent HIV itself in women of reproductive age. How do you do that? And their partners, how do you do that? By what the common ABC that we used to talk about. As a pharmacist, you are expected to be involved in this first part, where you talk about abstinence, you talk about being faithful, you talk about the use of protection when a woman of reproductive age is going to be involved in any sexual activity. But if we fail that first part, we go to the second aspect, which is prevention of unintended pregnancies in women that are of the same age. Now we have failed the first aspect, the woman is already positive. So the next thing is that there should be no unplanned pregnancies. Before they talk about pregnancies, the woman and the partner should discuss, how are we going to have this? What is a viral load now? What is my own viral load now? They should discuss it so that as much as possible, the child that is going to come up will be at lower risk of the infection. Then if the woman is not pregnant, we'll go to the third stage, where we'll talk about the prevention of HIV transmission from the mother to child. This will talk about the use of drugs in the patient. Once upon a time, we'll talk about using the nevirapine only, then they move from the nevirapine base to a efavirenz-based regimen. At present, we use the dolutegravir for even pregnant women, as was discovered, as we presented last year at the IAS conference, that they can use the dolutegravir-based regimen as well, and it should be of no problem. Then for the family, the infant, the child is giving birth to, the child is not a child that is heavily predisposed to the infection. You give just monotherapy, nevirapine at birth immediately for 6 months. But if the child is at high risk, a child is called to be high risk if, one, the mother was not aware of her status, was not taking her medication during the pregnancy, or the woman had prolonged labor. This child is called a child that is at high risk of infection. Then in that case, they do dual therapy, the combination of nevirapine.
Hello?
I'm sorry, I think it's the network.
Yeah, it's network problem. It's equally raining here heavily.
Okay.
It looks like the rain is general.
Yes, somebody told me that it's also raining in Uyu as well.
Exactly. Everywhere. Heavy rain.
And it's raining in Warri.
Same in Port Harcourt, so rain everywhere.
Oh, wow.
Raining in Kefi.
It's a national rain. Sorry about that. So can we continue?
Yes, we can.
Did I get to the point of the post-exposure prophylaxis?
No, you've not entered them.
Okay. But did I talk about the highly exposed infant that's on dual therapy?
Yes, okay. Exactly.
Okay, so we'll go to post-exposure prophylaxis. So in post-exposure prophylaxis, the interest is we have someone that is HIV seronegative that has been exposed either through occupational hazard or non-occupational hazard. Occupational hazard, we have instances of needle stick, we have instances of accidents or during surgery where a clinician is caught, or in non-occupational hazard, as we have a road traffic accident, as we have in sexual assault, where we have the fear that somebody has been exposed to HIV infection. This person is provided a therapy that is called post-exposure prophylaxis. Here, it involves the use of ARV for 4 weeks, not later than 7 hours after the 72 hours, sorry, after the exposure to the HIV. Remember, this is for HIV seronegative individual. That means it is very important that within the 72 hours they are going to commence therapy, there must be HIV testing to confirm that this patient is not HIV positive. Because if it's HIV positive, there will be no need for PEP. Rather, he or she should be enrolled to HEART directly. Now, we now have what we call pre-exposure prophylaxis. This is the provision of antiretroviral drugs for HIV-negative individuals to reduce the risk of acquisition of HIV, because there are people that we consider to be at high risk of acquiring the infection, who is considered to be at high risk of HIV infection. We classify them into three. The first is anybody that is involved in sex and that in the past 6 months of reporting to the clinic, the person tells you that I am sure that my partner or my partners are HIV seropositive. Or the person tells you that in the past 6 months, I have been involved in sex, and for the 6 months, I have not been consistent in the use of protection. Or the person tells you that in the past 6 months, I've had 1 or 2 cases of STDs. This person is a candidate for pre-exposure prophylaxis. We also have people that we call injection drug users. These people that are involved in administering psychoactive substances to themselves, whether the person is using it himself or herself, or the partner is the one that is using that. That person is at high risk of acquiring HIV infection and should be placed on pre-exposure prophylaxis. Then the last is the person that has had multiple causes of PEP. Whether the person tells you that it is through occupational or non-occupational hazard, as long as it tells you that in the past 1 year, I've taken PEP 3 times, 4 times, no, this person is at high risk of infection and should be placed on pre-exposure prophylaxis. As of today, and in Nigeria, for instance, we only use the oral daily pill in the management of pre-exposure prophylaxis. These three are what we have today in the management, in the prevention of HIV. But what are the emerging strategies that are being used now in the prevention of HIV? The first is in young women. When we say young women here, in this instance, we're talking about people that are between the ages of 16 to 21 years. Nair et al. Conducted the study and represented it at the last conference that when they compared the use of oral pre-exposure prophylaxis, that's tenofovir and emtricitabine, and dapivirine vaginal ring for women that are between the ages of 16 to 21, they observed that the two strategies were able to prevent transmission of HIV in more than 90% of the patients or of the clients, since they're not necessarily patients, they're not positive. So let's just call them clients. And all these people, 50% of them accepted the ring that is easy to use and they could adhere to it, while about 60% adhered to the use of the oral PrEP. It made the conclusion that for both, either is oral PrEP or is the vaginal ring, any of the two could be prescribed for a young woman that's between the age of 16 to 21 who is at high risk of being exposed to HIV infection. But for the older people, a test was conducted to confirm whether they will use the same oral PrEP, that's tenofovir and emtricitabine, or they should just be given a new drug, cabotegravir, which is an injectable PrEP. This study used about 3,000 patients in South Africa, Zimbabwe, and Malawi. And it came to a conclusion that cabotegravir was able to prevent the transmission of HIV in 91% of these patients. And the only 4 people that had the incidence that made it to the 91%, one had adverse effect to the drug and stopped using the drug. One was positive at the baseline but was missed. Another person had issue with adherence, and one said that she was using the oral PrEP before and now started using the injectable PrEP. So for the conclusion of this, it means that for the older women, they have a choice to use either injectable PrEP or to go for the oral PrEP. Now, for the pregnant women, because somebody may ask, what about the pregnant women? Because in health sciences, we're interested in what happens to the women of who are pregnant, because not all drugs have the same pregnancy classing in terms of our A, B, C, and X. So another test was conducted still in Africa, South Africa specifically, and also Zimbabwe, to look at the safety of the oral PrEP and the dapivirine vaginal ring in women that are pregnant of all ages. Some of them were even as young as 18 years, and some were as old as 45 years. And the pregnancy was for all the stages of the pregnancy. At the end, whereas it was found that the strategies, either the oral PrEP or the vaginal ring, were able to prevent the transmission of the infection in those women, the complications that were found were very few. And some of them were complications that were also found in pregnant women in the same clinic who were not HIV negative and who were not on this our regimen. Because they talk about having hypersensitive disorders in 4 women who were on the oral PrEP. Also, in case we talk about, what about those women who are on hormone therapy for any reason? Is it for feminization? Is it for contraceptives? A study was conducted also in Spain to look at the effect of this hormonal therapy on the drugs that are used in PrEP, both the tablet and the injectable. It was found that it only slightly decreased the level of the drug regimen to an extent that it has no clinical significance. Now, somebody may now say something that, so if we're talking about having PrEP and it's preventing HIV, and we're giving it to people who are not HIV positive, is there any fear that it could lead to, some people will say, unwholesome act? Some will tell you that, will it lead to drug resistance? Will it lead to people not being careless since they believe that there is PrEP? Well, a study was conducted to test that, and it was observed that in 23% of the people that were on either gemcitabine or tenofovir, there was the isolation of resistant strain of HIV after being on PrEP for a prolonged period. What this tells us that yes, the use of PrEP could predispose the community, the public, to having different strains of HIV that could be resistant to or existing drug. Therefore, it is important that for a patient to be exposed to any of the PrEP, we should advise them about improved identification before they start. Let us know that they are actually HIV negative. Let us find out that they are able to adhere strictly to a treatment plan. And finally, we should be able to understand that if at all they're going to be on this regimen for a prolonged period, periodically there should be tests for resistant strains among the patients. That is for prevention. What do we have about treatment? We've also had old and new information about the treatment of HIV, management of HIV. For treatment, we all know that the mainstay of treatment for today is what we call our HAT, the highly active antiretroviral therapy, where we talk about the combination of drugs from different classes that can affect the virus in at least 2 points that are important in its life cycle. Based on the most current guideline that started from as far as 2015, we now have what we call test and treat. Once a patient is detected to be HIV positive, on the day that the patient is found to be positive, the person is placed on therapy. Whether it's an adult, pregnant woman at any stage of pregnancy, either it is first trimester, second trimester, third trimester, or even at the point of labor. Whenever the pregnant woman reports to treatment, he or she is placed on treatment immediately. And even infants from their first year of life, they are prescribed drugs in the management of HIV. As of today, where are we on treatment? Treatment mainly today is using either of the combination of tenofovir, lamivudine, and dolutegravir, or in some people who cannot tolerate dolutegravir for whatever reason, they are placed on a efavirenz-based regimen that still has the same tenofovir and lamivudine. So we have our once daily single tablet regimen where the patients are given drugs that they are taking just once a day, but for the rest of their lives. Different strategies have been brought up to use in making the patient to be adherent. We have the differentiated service delivery, whether it is at the scripting level, is at community-based, or in community pharmacies, or even in the hospital, where a patient comes for just maybe once in 6 months, gets drug. If there's no complication, he or she can take medication from a nearby facility that must not be the main treatment facility. And this has led to an improvement in both clinical and humanistic outcomes for the patients. We've had reports of good control of viral load and even immune function. We've had reports of reduction in the mortality to HIV and different humanistic outcomes like improvement in quality of life of the patient. This is existing and it's working in almost every facility, including in Nigerian facilities. So we have patients that are on first-line regimen or those that are on second-line regimen based on these clinicians' assessment, the patient starts the medication and they are on it for life. However, we have newer strategies that are coming up. Somebody may ask, if we now have something like TLD, the tenofovir lamivudine and dolutegravir, or TLE, tenofovir lamivudine and efavirenz, and these two have been found to be safe, have been found to give us good clinical monitoring outcomes. Why are we looking for newer strategies? The first is, as much as they are good, as much as their benefit outweigh their risk, they still have instances of adverse reactions. We still have a problem of cost. You will know that in the management of HIV in Nigeria, for instance, any facility in Nigeria that is managed by the government of Nigeria, as they call it, you have incidences of out of stock. You have incidents of a patient being on a particular regimen, they tell you that for 6 months, they have not had medication. Therefore, they give the patient another medication. They tell the woman is pregnant, they don't have drug for the woman. Let her go and come back. And different, because of the cost, our governments cannot provide them. And because of the supply chain that disrupted in Nigeria, it's very difficult for you to see that you have consistent supply of the expensive brand. Then imagine a life of taking drug forever. Even though the clinicians, especially the pharmacists, are involved in counseling on how to take their medications, they will still have problem of patients complaining that their only concern is that they have to be on drug for the rest of their life. Then we also have other comorbidities like tuberculosis, cardiovascular diseases that have affected the compliance to their medications. And finally, until we have a cure, we can't relax in the management of HIV. So what are those new regimens that have come up in trying to treat HIV to take care of any of these problems that we have listed? The first that we mentioned today is what we call the ART desimplification. What desimplification means is that earlier I mentioned that All-Star is once daily single therapy regimen where a patient is given just one drug to take once a day. This has been found to be very effective, but to be very expensive as well. A study was conducted to look at the difference in cost between using this one tablet and using just 2 tablets of the same combinations. It was found that the cost was about half of using the one that is of that single tablet. It means that in those low and middle income countries, they can choose to use ARTs that are desimplified from single tablet to 2 tablets, and it will be very effective in the management of the infection. Of course, somebody will tell you that, but it will increase the pill burden on the patient. Yes, it will increase the burden. That was the only adverse report that was presented in that study. Now, we also have a new drug that's called lenacapavir, which is from a new class of antiretroviral drugs that are called HIV capsid inhibitors. In a study that was conducted called the Calibrate study, they gave this drug just 1 injection every 6 months. That is 2 injections subcutaneously in a whole year for the management of HIV. It was found that after 28 weeks of treatment, 94% of all the patients, over 3,000 people that were on this medication, had viral suppression. In other words, they had viral load that became undetectable. Although those that were on oral had 100%, but this 94% is a pointer that perhaps if those side effects that made the patients to relax in their compliance, like injection site reactions, like having hardening of the skin injection site, are removed, then it means that we could have 100% in the use of this long-acting injectable antiretroviral regimen in the management of HIV/AIDS. Apart from this, there's also the Capella study that look at the potency of using islatravir and doravirine for the management of HIV in patients that are on first-line regimen. This also found that the drug is very effective. It could lead to viral suppression in the patients as well, but it is still under trial because the adverse drug reactions have not been evaluated in full. Now we have the other baby in the market now, what we call the Cabenova, the combination of cabotegravir and rilpivirine. The FDA approved this in 2021 for the management of HIV as first-line therapy. In this case, we have two different injections that are packed together in one container and given to patients. Either you give them once in a month, or you give them 2 times, 2 injections of 7 days, within 7 days, and they'll be like that for 2 months. We'll call it the plus dosing. The single dosing is that they take one injection once, they take the 2 injections once in a month. But if you could give them within 7 days, repeat the dose within 7 days, then for 2 months, they will be without any drug. This is already being used in some facilities outside this country, and it's also reported to be very effective as the oral therapy in non-inferior studies. Some people could use what we call the oral lead-in dosing. What the oral lead-in dose is about is that just like we used to have in the nevirapine lead-in dose, in oral lead-in dose in Carbenova, what is done is that you give the patients oral tablets, oral drugs of the same Carbenova, separate cabotegravir and ripivirine. You give them for some time before you switch them to the injectable Carbenova. They also have newer strategies now that whenever a patient fails first line, either through clinical failure or what we call virological failure or what we call immunological failure, not talk about taking them to second line therapy. Some patients still fail this second line therapy and they will require what we call third line regimen, and in some instances, salvage regimen. To do this, 2 drugs have been reported that when they are combined with the ARVs in the management of patients, especially adults who have multi-drug resistant HIV infection, then the possibility of having viral suppression early is improved. And the first drug is that for Tenofovir that is used, and Ibalizumab, that's also just an IV infusion that's administered every 2 weeks in combination with the ARV. Now, there's also one funny thing that's now happening. A study was conducted that, because if you remember, our patient, one of the problems with the patients is that if they move from first line to second line and third line, there's an increase in the number of pills. There's an increase in the pill body. A recent study observed that if a patient is failing any of the NNRTI that is combined with tenofovir and lamivudine, then you could just remove the NNRTI and replace it with the TLD brand, tenofovir, lamivudine, and dolutegravir as second-line therapy, and it works well, as we have in even the one that we use boosted protease inhibitors. Now, if we have HIV in a stage that we can treat and will not have any issue, is there any consequence of patients living longer with HIV? Yes. It has been observed that there's a higher risk of age-related conditions in patients who are on HIV medications and who live after the ages of 60 and 65. Incidences like attendant fall, incidences like increased mortality has been reported in this group of patients. It therefore means that as much as we're talking about treating our patients with antiretroviral regimen, we should also consider that they have issues with mental health, especially depression, that should be considered in their management. We should talk about how to maintain physical activities to an extent that even at that age, they should not be at disadvantage in terms of being exposed to a higher risk of falling and not unhealthy. Then finally, since they have increased susceptibility to comorbid conditions, especially cardiovascular diseases and diabetes, then we should look at how we manage those comorbidities in a way that will not make them to be at a disadvantage in the management of HIV as they live long. Now, we will not end this. We're talking about where are we going to? Where is science leading us to in the management of HIV? People wondered that how was it possible that COVID-19 could have a cure in less than, so could have a vaccine in less than a year. Yet, for about 20 years, scientists have been involved in the search for a vaccine for HIV without any success. The reasons have been profiled by different people, but evidence shows that perhaps one of the main reasons is that there was politics in COVID that has not been in HIV. Whereas HIV was no more a problem for the whole world, COVID-19 was a problem for the whole world, therefore there was greater investment in it. But apart from that, we also have some scientific proofs that show that it is more difficult to get a vaccine for HIV than we have for COVID-19. One of it is that unlike the COVID-19 that can be cleared by the immune system, the HIV, the virus in this case integrates with the host CD4 count, and so CD4, so it becomes more difficult to clear it of the virus. Then we also have incidence of variances in HIV strains. In fact, just in February, in a publication in the England Journal of Medicine, they reported that a new variant, VB, of HIV was detected in Netherlands. So you can imagine that as we're talking about looking for a vaccine for what we have, newer strains are coming up at rates that are higher, that are faster than what we have in COVID. Up to that in COVID, we stopped at the Delta strain, but in HIV, you could count several strains that have come up. Although currently, there's the mosaic study that is going on, and we expect the result to come out in the next 2 months during the IAS conference. We hope that it will give an insight into a success in finding a vaccine for HIV. There have been attempts for cure in HIV in the past. We had the issue of the Berlin patient, the first Berlin patient, the second Berlin patient, unfortunately the first has died, who had stem cell transplantation. And after the transplantation, it was observed that they now had undetectable viral load without any ARV, without any antiretroviral regimen. This is something that is possible, but something that is very expensive and also comes with risk of other adverse reaction. Then we have 2 other cases. One is called elite controller, another one is called post-treatment controller. What do you mean by these controllers? The elite controllers are people who maintain undetectable viral load, even when they have never started ART. Somebody is HIV positive, test has shown that this person is positive, and the person is not on any medication for 2, 3, 4, 5 years. The person remains undetectable. They are called elite controllers. 2 instances have been reported, and these 2 people up to today are said to be HIV. They are HIV seropositive, but they are undetectable and are not on any medication. We have post-treatment controllers who start regimen and stop taking. They were on their medication, then because of adverse effect, because of pregnancies, they stopped taking their medication. And they never had any issues since they stopped taking their medications. These 3 instances now, stem cell transplantation, elite controllers, and post-treatment controllers give an idea that indeed it is possible to get a cure for HIV treatment, for HIV. But how that will be done is left for you and I, who are on the field, to look for a solution to it. In conclusion, I must say that the science of getting a cure for HIV is a continuous one. It will not relent until we get a cure for it. And you and I, as pharmacists, have different roles to play in this field. Is it in drug discovery, looking for newer targets, looking for drugs that are safer, drugs that are more effective, that the potency is higher, that have less side effects? Pharmacists must be involved in this. Then those that are currently in practice, that are dispensing the medications, that are providing any form of counseling, patient care in general, and any form of pharmaceutical care. Every pharmacy that has anything to do with the patient, you must play a role that leads to getting our patients to be better and to have life that is free of the stigma of HIV. Then we could also be in different researches. Is it clinical outcome research, economic outcome research? Is it humanistic outcome research, or about the utilization of HIV? Pharmacists have a lot to play. So if you are in the hospital, you are in the community practice, you are in the industry, you are an academic, contribute your quota in the management of HIV. Because if you don't do this, HIV infection in one person in the whole world is the same thing as HIV in the whole world. Because as long as that one person is there, then they see the risk of transmission of the virus, either through vertical or horizontal transmission. I thank CPAN for creating this platform to be used for the clinical presentation. I personally have been learning a lot from the clinical presentation. I thank the education committee that found me worthy for this presentation tonight. Of course, the audience that have not disturbed us throughout this presentation. Thank you very much. These are some of the references that we have used. Thanks for your time.
Thank you so much. Maybe I'll begin to change Dr. Isa to Professor. This is really wonderful because you're almost there. You're getting close to there. And every academic is always looking forward to be called a professor, which we know is just a matter of politics. Maybe because you are so much young in the university, they want you to reach a particular layers of years before they can give you the professorship. But all I know is that whatever it will take to be there, you're already there. Thank you. That is a wonderful presentation tonight. So we are glad you really did a justice where your bias is integrated or ligated in HIV. You've shown to the audience and to the Hope Sipan community and family that really, you knew what you were doing, and more advancedly, you've gone deep in the research about HIV and other related infectious diseases. Ladies and gentlemen, we are still waiting in the house, our national chairman. He has not actually arrived, Dr. Joseph Madu, but I can see a couple of other people in the house, like the WPCP Nigerian chapter chairman, or secretary, rather, or secretary of Faculty of Clinical Pharmacy. Let me not misquote, Dr. Chineyon Dugo. You're welcome, ma. We have Dr. Agada Ichofu. You're welcome to the house. Dr. Adeline Osakwe, you're welcome. My own closest friend, a very vocal one, a cardio-psycho pharmacist, Dr. Peter Alfosius, all the way from Plateau State. You're welcome. My own clinical enthusiast, Dr. Rachel Dasanya, and a consultant equally. You're welcome to the house, ma. Dr. Eugene Okuan is here. There are many of them, but even our own vibrant industrialist, a clinical pharmacist equally, and a lover of the pharmacy profession, Dr. Loluojo, is in the house. You're welcome, sir. You're welcome, sir. We are happy that you are here with us. You're always there with us all the time. That shows the deep love you have for pharmacy profession. Just like one of my friends will always say, Solomon, I did not read pharmacy, but when I have you as a friend, I always believe I'm a pharmacist. So pharmacy is a noble profession, but one way or the other, we keep dribbling ourselves and pulling ourselves down. But one day, those factors that bring us down will be removed from the profession so that we can fly. Because as even our national financial officer here is there, Dr. Obiajuru Wemaru, you're welcome. Many other people. We know one day we'll get over this. And my own big auntie and mommy in the house, Dr. Uche Chimo is here. Is a very nice woman. You're welcome, all the way from Imo State. So Imo State is represented, Imo State in Muremad. So at this particular juncture, I will leave the floor open for appraisers, for comments, for contributions. Please, if you want to talk, you can unmute yourself. If you want to ask questions, you can ask questions to the presenter, Dr. Issa. If you want to contribute, you can contribute. Let me not keep on talking because it is not my fault. Even as a moderator, I'm equally a master of ceremony, whatever. So I talk, say Solomon talks too much. It is not my fault. It is one of the problems I got from studying pharmacy practice. Thank you so much as we welcome people to react as we move forward. Reactions, reactions, reactions. Please unmute yourself and talk if you want to talk.
Hello, Dr. Solomon.
Yeah, go ahead.
Yeah, I just want to thank the presenter for the excellent presentation. Before I came on board, I was just really wondering, what are we going to learn from the new strategies for HIV management? By the time I listened to him, I've learned a lot. Thank you very much, the presenter. God bless you.
Thank you. Thank you. The next person. Next person, I know in Africa, they say, if a woman prepare food very, very well, very sweet, the person will go one participate to chop the soup. If he tastes the soup, ask who come. Now, when you finish eating, you go ask, this food where I chop, say, who can serve? So as Dr. Issa don't cook a nice soup here, people don't go bother to ask questions or that praise more. The point is that just like, that's what he said. He don't even know say you go let anything, but when Professor Issa begin to talk, he say, now we say there are much things to talk because he knows how to cook. He's a very good cook. In Igbo land, we say somebody in a tofe and somebody in a siofe. They are two different things. So it's things for us to learn and keep. Because of the rain that is falling everywhere in Nigeria, maybe it's trying to wipe out the hardship in Nigeria. It's a very good one. Somebody is raising, okay, our own erudite industrialist is raising his hand. Dr. Lolojo. Dr. Lolojo, sir, you can unmute yourself and talk,
yes,
sir.
Thank you. Okay, I'm unmuted now. Can you hear me?
We can hear you, sir.
Hello, Dr. Solomon, can you hear me?
Yes, sir. We can hear you.
Okay,
sir.
thank you.
Yes,
Thank you so
sir.
much. Good evening, everyone in the house. I want to thank erudite speaker, Professor Issa, for a good presentation. I joined late, but a substantial part, and I necessarily on this topic, and Professor Issa's presentation is fantastic, and we get it, and definitely it will go into my material. Now, I'm concerned about impact. Impact in the sense that our area of specialization generally at the non-minding the subunit is the drug. And when Dr. Awofisayo presented the other time, he made he pointed that we can have some simple things that the product that we are dealing with is real, because we know we still have a big problem with spurious drugs as it is today. So when it comes to HIV treatment, the new strategies, I want to see how much emphasis we are putting on the drugs, how we get it, whether we get it in adequate amount, the cost about it. And the quality too, whether it's the right one and the pin the right way. I'm just looking at how we can have that impact, pharmaceutical impact, in a way that people, wherever we are, can feel us. There is nothing anybody can do, no matter how brilliant you are, as long as medicine is concerned, therapeutics is concerned, you need drugs. And since we are the ones that are in charge, I think in every area that we are discussing, or we are on impact, pharmaceutical, and thank you.
Wow.
Hello, Dr. Solomon.
I can hear you, sir. The network is just our
Yeah,
enemy
I
tonight.
know network is a challenge. Yeah, I finished.
Okay, sir.
Finished my
Thank you, sir. Thank you for that wonderful contribution. Thank you so much, sir. Dr. Anne Imoru. Dr. Anne Imoru, are you there?
Yes, good evening. Thank you very much for the presentation. Dr. Issa, thank you so much. Very expository. And Dr. Solomon, thank you for your coordination. My question is on regards to the drug. I know he was mentioning some drugs that are now being used. I wanted to ask this, there's this combination, this dolutegravir and lamivudine and tenofovir. Is that among the newest trend in treatment of HIV, like for a person that has just been newly diagnosed with HIV? Is that the new trend now? Is that the latest? Or is there any other one that came after that? Because knowing that the newer ones are more effective and have lesser side effects. So that's one of my questions. Then secondly, he made mention of these injections that can be taken once a month or twice a month, or taken, for some time, and then you are off your medications for some time. Are those injections, are they available in the country right now? And is there any possibility of a comparative cost? Because I'm very happy he compared the cost of maybe taking a drug that instead of taking a single tablet that has a combination of all the drugs in it, you now take like 2 tablets. Like 1 tablet is just 1 drug, maybe tenofovir, but the other one is lamivudine. If I like the way he did that comparative cost, saying that most of the time the cost of the individual ones that are separated is less than that one that is combined. So is there any comparative cost with this injectable? Because it sounds very attractive as one of the new strategies. I'm sure it will be something highly appreciated for people that probably are just being newly diagnosed of HIV, and possibly those that are elderly that don't have that luxury of always coming for their refill and probably remembering to take their drugs as well. So those are the 2 questions: the injectables, and then yes, another question is if there's any for these drugs that these new drugs, do they have any specific counseling that should be done for those kind of patients that are on these newer brands of drugs? Is there anything that should be done, especially now that we're talking about comorbidity like cardiovascular and diabetic, as in diabetes being one of the comorbidities they have? Is there any separation? Can these drugs be taken alongside these other drugs for chronic conditions, or is there recommended time spacing? Okay, I think that's it. Thank you very much.
Okay, thank you. Dr. Solomon, can I respond now?
Yes, you can.
Okay. For the first question, yes, the latest medication for heart, based on that 2021 guideline, remains the combination of tenofovir, lamivudine, and dolutegravir, or when we replace dolutegravir with efavirenz, based on different assessment that we have for the patient. That is what we have in terms of treatment guideline, especially for the low and middle income countries. But in a place like US and UK, where the clinicians have the liberty of using medications based on what they find in the patient, that is where those our injections that we just mentioned come in. Unfortunately, none of them is currently available for use in the HIV setting in Nigeria. Why I'm saying that is that some of these drugs are available in private organizations in this country. They are using them in private facilities. We have some people that are big men on quotes, that sometimes they don't want to be seen in any HIV clinic in this country.
Yeah.
So they go to private hospitals, and some of them are placed on some of these medications. But see, one of the problems with this medication, why it will be difficult for you to come to Nigeria currently, is the issue of Dr. Lolo Joe mentioned something just now. The supply chain of HIV medications in Nigeria is very poor. If your facility is not being managed by any of these multinational companies, you always talk about out of stock, out of stock, out of stock. So for this type of drugs to be released to Nigeria, the issue of how to manage the supply chain will have to come in and has to be considered before they talk about it. That is why up to now, in the use of our PEP and PrEP, there was a time that we started our own PrEP with PMTCT. After a year or two, it was withdrawn by PEPFAR and APIN then because of our management of this medication. So it may take a longer time for us to have this drug in our own environment. The specific counseling for most of the injectables, the main counseling that we have, like we mentioned, has to do with injection site reactions and sometimes formation of lumps at the site of injection. Then for the pregnant women on PrEP, we talk about the incidence of the cardiovascular disease that came up in some of the patients. And so there could be counseling tips that we give to those patients as we're going to give them the medications. Then for those of the dequavir vaginal ring, all the people that have used it have not reported any issue of inconvenience. There's no issue of irritation. So it's one of the best drugs that's being used now for PrEP in other parts of the country. But I am aware that even up to now, we don't have the DPV, that's the vaginal ring in Nigeria at the moment. We only have the oral tenofovir and emtricitabine for the use of our patients for PrEP.
All right, thank you so very much.
Thank you so much. That is wonderful. As we still move, Dr. Ann, I know your questions are cleared. And secondly, based on that, you know, most of all these drugs are enzyme inhibitors. Just very few of them might be enzyme inducers. So if any particular one uses any particular isoenzyme, you can do a staggering mechanism and widen the gap so that there wouldn't be interactions. Interaction can occur from any particular site, their receptor sites or through chemical site or through any particular site. So if peradventure you want to assist as a pharmacist, you may make do with the issue of widening. Just like, as Dr. Isa said, like the dolutegravir, we equally know that it has a way of increasing cholesterol in the body. It increases the TG, increases LDL. So those things, those factors down might lead to much increase in all those things. The patient will be canceled on that. And equally, it has a lot of mood changes on some people. It causes some issue of weakness at times to some layers of patients. But you bring all those things down for them and they equip them to have all those things in mind. And as a pharmacist, many things are always in the head. So thank you so much, Dr. And thank you so much, Dr. Ann, for bringing into bear those things that will fully expose our curiosity to learn more and add to the bank of our knowledge. Dr. Alphonsus Peter raised his hand before. I don't know whether if what Dr. Moro asked is what he wanted to ask, or they have alliance, or he decided to raise his hand down. I don't know, Dr. Peter Alphonsus. We would like to hear from you.
Good evening, Dr. Isa. Good evening, Dr. Solomon. Can you hear me?
Yeah,
Yes,
welcome, sir.
We can hear you.
Okay, wonderful presentation, Dr. Isa. I must say, state of the art. And like you said earlier, a lot of us had one form of practice, either as volunteers in HIV pharmacotherapy and HIV clinics. And that is what you cannot take from so many pharmacists. Recall that HIV is one of the major ailments that have made us relevant today. All the pharmaceutical care a lot of us are talking about maybe started from that angle. Quite well, I remember when I was doing internship and a lot of HIV patients come on board, people were afraid to even have contacts with them. A few of us actually took the lead and we actually got a lot of experiences with that. Suffice me to say again, that just like you have said, there's a lot of association between some mental health issues with HIV. Depression and the likes are usually associated with HIV. So most of the patients come into the hospital with that issue, aside leaving the side effects that Dr. Solomon just spelled out just now. Now, one other issue that used to be very common especially with ladies when they want to get married, and maybe they have a fiancé, they want to get married. One church or one religious place that asks them to do HIV test and submit the test, and they come and discover that they have HIV. You will discover that some of them will be looking for how to share this HIV. It used to be very common at some point in time, and a lot of NGOs started supplying condoms, for prevention. So even among these HIV patients, in as much as we're talking about drug use, a lot of condoms were being distributed, and some patients would actually, both male and female, reluctantly collect this. Most of them will be wanting to share. The conventional Nigerian thing, I don't want to die alone, I don't want to have these issues. Although it's been debunked in so many ways, but so many people today, that stigma when it comes to HIV is still there. So we as pharmacists have a lot to do. Now, Dr. Rachel just spoke some time back. I had a collaboration agreement with one of the physicians, consultant physician in one of the hospitals in Jos, and she used to refer some patients to me. Amongst those patients she used to refer to me were patients that had issues with mental health status. So I gave her some parameters then, and she saw those things, she agreed with it. On one of those instances, she called me. And when she called me, I went to see a patient. Of course, most of these patients are on multiple medication. The man had some, adverse drug reaction. And because I know Dr. Rachel is an expert in pharmacovigilance, I didn't know much about that. I had to call her. So I linked them, so that they could talk with this other consultant. The point is that most of these patients that take the HIV positive are on so many medications, the drug interaction and the like. And these are opportunities for we pharmacists to take charge. But unfortunately, you go to some hospital, you just see the pharmacist just only dispensing, and the technician is sitting down. And the communication. So we need to find ways that these medical doctors will trust us, so that when it comes to drug-related issues, be it adverse effect, be it the question that Dr. Ann just asked or the likes, the medical doctor will feel comfortable to come and meet with the pharmacist. I don't know how many of us that are into HIV therapy that the medical doctors would decide to, how would I put it, to probably delegate the patients into your arm because it feels you are a drug therapy expert. And I know that until and unless we do that, we will just be calling ourselves experts, whereas those that are working in our own expertise are not recognizing us. HIV has done a lot in improving the pharmacy profession, especially pharmaceutical care, like we all know. And just like you have said, other issues like cardiovascular disorder and the like. So HIV still remains one ailment that is supposed to improve pharmacy relevance in Nigeria if we get it right. Then lastly, is a question to Dr. Issa. I don't know if you are involved in any way in differentiated care, where some community pharmacies were supposed to be penciled to work with some patients from designated hospitals. I discovered that most of those places, you have core community pharmacies that are not even being carried along. You see some people that do not even sit there. They will use politics and get those patients. Patients go to their place, and at the end of the day, it's one technician or one sales guy that is giving the patients or dispensing antiretroviral. So the whole essence of pharmaceutical care is not being met. I don't know how NGOs are handling that, or how you guys are doing it, those of you that are calling to HIV. Respect to differentiated care. Thank you.
Thank you so much. Thank you so much, Dr. Peters. Dr. Issa, you have to react to that so that.
Yes, I was just looking for somebody who was online recently, but he has left now. There was a master's student in a department that worked specifically on differentiated care model among community pharmacists in Abuja and Nasarawa State. And very frankly, he mentioned some of these things that I just mentioned now, that it got to the time that it turned to more of politics and business than pharmaceutical care delivery. That what people considered mainly was, how do I get more patients in my facility so that I can be able to get more return on investment and things like that. The work is still ongoing and has not been published, but the report that we're getting so far indicates that our colleagues in those services, especially those in the community pharmacies in FCT and National State that he studied, are not giving much attention to the PC aspect of the differentiated care delivery as compared to whatever return they can get from the patient.
Thank you so much. Thank you so much. There is somebody that's equally a consultant infectious disease pharmacist that work with me in Federal Medical Center, where he really wants to make a contribution equally because he has been in HIV for years. He has gone to many trainings. So he has something to add that will make the fluidity and the conceptualization of this topic a much better one. Pharmacist John Uzoma is from Federal Medical Center, Owerri. Pharmacist John, if you're in the house, you can unmute yourself and contribute.
Thank you, Dr. Solo. Wonderful presentation from Dr. Issa. Well done. I just want to make a brief contribution and also ask one or two questions. Dr. Issa, while you were presenting, you typically mentioned about prevention and treatment. That's the current state of HIV management. We should commence not later than 72 hours after exposure. So I want to find out what's your patient hours? What's your direct?
Hello, I didn't hear the last part. Hello.
Can you hear me?
I didn't get the last part. When you mentioned 72 hours.
Yes, you mentioned that patients should present for PEP not later than 72 hours after exposure.
Yes.
So I'm not asking, what happens if a patient comes after 72 hours? What's your take? That is one. For the pre-exposure prophylaxis, you mentioned that we are only doing normal daily pills now. I'm wondering if the event-driven has not been enforced in Nigeria at the moment, because in my facility we also do for event-driven, we give them pre-exposure prophylaxis. For pre-exposure prophylaxis also, you came from the angle that it's only a biomedical approach. Behavioral approaches are no more part of pre-exposure prophylaxis. When you talk about TLD, Dr. Bellamy would.
It's breaking.
Is it breaking?
Yes.
Yes, the network is really bad.
Breaking.
Okay, I don't know if it's clear.
It's clear now. I think it's as if you are moving from the mouthpiece.
Okay. So I was just looking at the exposure prophylaxis.
Yes.
Only majorly about the biomedical approaches, and we didn't hear much about the behavioral and structural approaches to prevention of for pre-exposure prophylaxis. So I don't know if you could say a little bit about that, because my understanding about pre-exposure prophylaxis is that it's a triple approach. It talks about both structural and behavioral aspects. Then finally, when you were talking about TLD being considered for a second-line regimen, you made mention of patients on non-nucleoside reverse transcriptase inhibitors that are on TL-based that are being moved to TLD. I saw a repetition. I saw a TL in two places. My understanding is that for you to move a patient from a first-line regimen to a second-line regimen, at least two of the regimens, two of the ARVs should be changed. Does that still hold? Thank you.
Okay, thank you very much. Let me start from the first one. The percentage of effectiveness of preventing the risk of transmission of HIV whenever somebody is exposed reduces as the time interval changes. The CDC guideline that we use talk about starting within 72 hours of assessment. But after 72 hours, the decision is left for the clinician after assessing the patient. If he or she believes that the patient will still benefit from the PEP after 72 hours, but at that rate, the percentage reduces to 58%. I have been involved in the retrospective review of the use of PEP in Nigeria, and I can tell you that we have a very good percentage of 96% effective.
Please unmute yourself. Allow Dr. Isa to talk, please.
We've gotten the report of 96%. This study I did in ABO Teaching Hospital and in UNTH, that for the past 10 years, the country has reported almost 96% effectiveness in PEP usage. And most of it were because those patients got their medications within 72 hours of exposure. So the choice of giving to a patient after 72 hours should be with the clinicians who believes that the patient will have any benefit from it. But ordinarily, the best thing is the earlier the patient starts it, the better. Then what I meant by the pill being available in Nigeria is that currently we have the once daily pill, we have the vaginal ring, and we have the injection, the injectable that is used for a month. So I mentioned that currently what we have as being used in the clinic is the oral pill. We don't have the DPV, and we don't have the carboplatin being given to patients in Nigeria. That's what I meant by that. Then finally, of course, when we say that pharmacists have a role to play in retention to PrEP, some of them have to do with the social, structural, and behavioral aspect, not just the clinical aspect. Because if we put too much effort on just the clinical aspect and forget about the social, structural, and behavioral aspect, then what I mentioned in a study that was conducted earlier, I told you that. Hello?
Hello, can hear you.
Okay, I mentioned a study, the GEMS project study that was published in 2021 that talked about the risk of HIV acquisition and drug resistance to antiretroviral regimen based on the utilization of PrEP. So if these social, behavioral, and structural factors are not well managed, and we just concentrate only on the clinical factors, the biomedical aspect, then we'll still run to the risk of having our drugs to become ineffective for use in our patient. Then finally, for the question about the switch to second line and using the dolutegravir, what the study compared was a patient being on an NNRTI with lamivudine and tenofovir. You know, when we're going to switch, we change the backbone, and also if the patient is on either of the lamivudine or lamivudine, we now change to zidovudine, or as the case may be. So in that study that was published this year, you will see it in the list of references. They compared patients being moved from the NNRTI plus tenofovir and lamivudine to just the same TLD that we have as first line in other patients, and it's found to be equally effective as combining the patient's drug with what we have as our boosted PI, either it is the atazanavir or the other protease inhibitors that we have. So that's what the study found out, and that is what is being implemented in some clinics now in the United States.
Thank you so much. Thank you so much. You've really done a justice to this. And I don't think people are still talking. This is just close to 11 o'clock. Is it because it's Saturday? Well, there are some people that have functions to do in Saturdays or attend churches on Saturdays. So at this particular juncture, I might begin to tell some other people to maybe to relax so that we can retire to sleep. So that we'll continue to cross-pollinate ideas in future times of our CPAN as a brainchild. So, ladies and gentlemen, our national chairman is not here. And incidentally, the national secretary is not here. I don't know, it's like maybe they are in another meeting, in another house. I don't know. So be that as it may, Dr. Isa has done really well. Has done really well this night. And all the people that contributed, even from John, all of them, even our own superlative industrialist, Dr. Luluoje, they did very well. So there is really fertile and creamy way of knowledge transfers from here. So at this particular juncture, I am thanking everybody that participated. I'm doing a vote of thanks that participated today, and believe that the next one will be another bomb, which will be a special edition. I am bringing forth a professor from University of Benin to do a justice to that. Professor Loretta will be the one that will be delivering 20th of this month. And it is going to be on a topic that people are interested in, neurodegenerative diseases. So I have a lot of contact with her. So she's already preparing her slides. So it's a wonderful one being with this family tonight. So at the closure of this, I will be able to look for somebody to do a closing prayer. And I don't know whether Dr. Yusuf Muhammad is in the house to lead us in closing prayer. Dr. Yusuf, are you there? Are you there? Yusuf, are you there? Ibrahim Abbas, please, can you lead us in closing prayer? All these people are present, but it's like they drop the phone. Maybe I go to be watching La Liga match in the other room. Fatima Sanusi, are you there? Well, in the absence of all these people, I have to wrap this tonight presentation with my own prayer. Father, I will thank you for this wonderful presentation tonight. You are indeed doing a lot of works in the growth of CPAN in Nigeria and beyond. I will believe we'll keep on getting it better with your blessings and with your care and love. To the time that CPAN will become a household name, not only in Nigeria, but in the rest of the world. To the point I would say, if you have not gone to reference a book, a journal of CPAN, you have not started as a researcher. God, we believe you do it for us. Bless everybody that participated here tonight, and keep on blessing us and keep on uniting us as one family, so that pharmacy will take its rightful place in Nigeria the way it is being practiced in the Western world. All these and many more ask in the name of the Father and of the Son and of the Holy Spirit. Amen. Good night.
Amen.
Good night, everybody. Good night, everybody.
Good night, all.
Good night, all. Thank you. Good night.
Thank you, the
Good night,
presenter.
everyone. Thank you very much.